The woman sat rigid in the wooden chair, her hospital gown creased where the leather straps cut across her arms and chest. The sting and convulsions of the recent electroshock still echoed in her muscles, leaving her stunned but not fully unconscious. Around her, the small office smelled of disinfectant and cigarette smoke, not of an operating theater. There were no surgical lamps, no sterile drapes, only a desk, file folders, and a metal tray of instruments. Walter Freeman stepped forward, the architect and evangelist of the transorbital lobotomy. He asked the patient to look up. Nurses steadied her head as he lifted the upper eyelid and slid the slim metal shaft of his modified orbitoclast along the curve of the eye. He rested its tip against the paper-thin orbital plate of bone. With a light hammer, he tapped. A faint crack signaled the instrument's passage into the frontal lobes of her brain. Inside the skull, Freeman swept the orbitoclast side to side, disrupting the white matter tracks that connected the frontal lobes to deeper brain structures. He withdrew the instrument, then repeated the same motion through the other eye. There was little blood, no dramatic incision, only the quiet rasp of metal on bone and the patient's dull moans. Within minutes, orderlies wheeled her away while Freeman calmly reached for the next chart in the towering pile. At the dawn of the 20th century, modern psychiatry still stood in its infancy. Vast institutions such as Worcester State Hospital in Massachusetts and St. Elizabeth's in Washington, D.C., housed thousands of people with schizophrenia, manic depression, or disabling anxiety. Wards were overcrowded, corridors echoed with distress, and staff struggled to offer more than confinement, sedation, and rudimentary talk therapies. Hope for meaningful, lasting improvement felt increasingly remote. In this therapeutic vacuum, physicians turned to drastic biological experiments. Insulin coma therapy drove patients into repeated unconsciousness, sometimes at the edge of death. Malaria-induced fevers, originally used for neurosyphilis, were repurposed in desperate attempts to jolt mental illness. Electroconvulsive shocks, delivered without modern anesthesia or muscle relaxants, provoked dramatic seizures. These methods occasionally brought temporary relief, but they also produced fractures, memory loss, and profound fear, with outcomes that remained unpredictable. Meanwhile, in Europe, researchers focused on the brain itself. At Yale, John Fulton and Carlisle Jacobson had shown that cutting frontal lobe connections in chimpanzees altered aggression and responsiveness. Portuguese neurologist Antonio Egas Moniz followed these findings closely. In 1935, he introduced the prefrontal leucotomy, inserting a specially designed leucotome through burr holes in the skull to sever small cores of frontal brain tissue. Moniz reported agitated, violent patients emerging calmer and more compliant, and presented his operation as a daring surgical answer to otherwise intractable psychiatric disease. In the mid-1930s, across the Atlantic from Lisbon, Walter Freeman sat in his Washington, D.C. office reading Egas Moniz's reports on prefrontal leucotomy. The idea that severe mental illness might be surgically disconnected rather than merely restrained or sedated fascinated him. In 1936, he decided to bring the operation to the United States, convinced that American psychiatry needed bold, decisive interventions instead of overcrowded wards and chronic custodial care. Freeman lacked formal surgical training, so he enlisted neurosurgeon James Watts. Together, at George Washington University Hospital, they performed the first prefrontal lobotomies in the country. Surgeons opened the skull with burr holes, then passed a blunt knife deep into the frontal lobes, sweeping to sever white matter connections. Freeman meticulously documented early case series, highlighting quieter wards and more compliant patients, while largely minimizing reports of blunted emotion, reduced initiative, or lasting cognitive damage. In 1949, the Nobel Committee awarded Egas Moniz the prize in physiology or medicine for developing leucotomy, granting psychosurgery a powerful stamp of legitimacy. Freeman, who had closely followed this recognition, felt vindicated and newly emboldened. At the same time, he grew impatient with the slow, technically demanding craniotomies that required skilled neurosurgeons. He began searching for a simpler route to the frontal lobes, one that bypassed the operating room entirely and could be performed almost anywhere. By 1945, Walter Freeman stood at a crossroads in psychosurgery. Traditional prefrontal lobotomy demanded an operating theater, a neurosurgeon, and hours of delicate work. Then he read reports from Italian psychiatrist Amaro Fiamberti, who had reached the frontal lobes through the eye socket instead of opening the skull. This transorbital route suggested a radically simpler path. No craniotomy, only the thin orbital roof between the orbit and the brain. Freeman seized on the anatomical insight that the bone behind the eye was paper-thin. In a morgue, he experimented on human cadavers, testing whether a simple household ice pick could traverse this barrier. He placed the tip beneath the eyelid, along the top of the eyeball, then struck the handle with a mallet. The ice pick punched through the orbital bone and into the frontal lobe. With repeated trials, he refined angle, depth, and force. In 1946, convinced it was ready, Freeman performed his first live transorbital lobotomy. He soon replaced the kitchen tool with a dedicated instrument, the orbitoclast, sturdier and etched with depth markings. The ritual became tightly choreographed. Electroconvulsive therapy induced unconsciousness. The orbitoclast slid above the eyeball, a hammer tap breached the bone, then a sweeping motion cut frontal connections. The entire procedure took minutes, required little equipment, and, critically for Freeman, no neurosurgeon. By the late 1940s, Walter Freeman had refined his transorbital lobotomy into a fast, routinized procedure, and he carried it across post-war America in a customized van nicknamed the Lobotomobile. Archival photographs showed the vehicle pulling up to sprawling state hospitals, its cabinets packed with instruments and patient records. From Iowa to California, invitations arrived from institutions struggling with overcrowded wards and desperate for anything that promised rapid relief. At places like Cherokee State Hospital and Stockton State Hospital, administrators confronted crumbling buildings, too few staff, and wards filled with people labeled violent or unmanageable. Early case reports, conference presentations, and enthusiastic word of mouth described lobotomy as a breakthrough. When Freeman arrived, some hospitals scheduled mass treatment days. Operating in treatment rooms or improvised theaters, he performed transorbital lobotomies one after another, sometimes in front of watching staff and visiting officials. On his traveling desk, Freeman organized index cards detailing thousands of cases, names, diagnoses, dates, and terse notes about outcomes. To many psychiatrists and superintendents, the operation's appeal lay in its speed and low cost. A single brief procedure could, in their view, turn a disruptive patient into a quiet, manageable ward resident who needed less supervision. Newspapers echoed this optimism, heralding lobotomy as a miracle surgery that restored order to chaotic asylums and justified expanding its use. In 1941, Rosemary Kennedy entered an operating room in hopes of relief from mood swings and behavioral difficulties. Under the supervision of neurologist Walter Freeman and neurosurgeon James Watts, she underwent a then-standard prefrontal lobotomy, not yet the transorbital ice pick technique. Surgeons bored into her skull and severed connections in her frontal lobes. As reports later described, the procedure dramatically reduced her abilities, leaving her with profound cognitive impairment and limited speech. Rosemary's outcome echoed through thousands of other lives, many altered by the later ice pick lobotomy. Depressed housewives, traumatized veterans, and adolescents labeled defiant or difficult entered state hospitals seeking help. Their files recorded insomnia, anxiety, nightmares, or arguments at home rather than violent psychosis. Yet, persuaded by physicians, relatives signed consent forms. The promise of a quick, bloodless procedure through the eye socket seemed, at the time, a merciful alternative to years of confinement. Records from institutions such as Ionia State Hospital in Michigan described stark before and after portraits. Patients once noted as articulate, creative, or ambitious returned from surgery quiet and compliant, but often apathetic. They struggled to plan, to work, even to follow simple routines without guidance. Some no longer cried or raged. Their torment appeared muted. But the cost was written between the lines: blunted emotion, childlike dependence, and the permanent loss of initiative and independence. Across the United States, newsreels and glossy magazines framed lobotomy as a daring frontier of scientific psychiatry. Outlets such as Time and Life described it as a streamlined solution to the post-war insanity crisis, focusing on dramatic before and after contrasts. Cameras followed patients as they left overcrowded wards, walked in hospital gardens, or sat quietly with relatives. Narration emphasized progress and modernity, rarely dwelling on the operation's risks or long-term consequences. Early case reports highlighted patients who had once been suicidal or violently agitated and now appeared calm enough to return home. Walter Freeman published outcome tables claiming substantial rates of improvement or cure, often counting any reduced agitation, fewer restraints, or easier nursing care as success. Loss of initiative, blunted emotion, or new cognitive problems were usually relegated to brief comments. Graphs, percentages, and reassuring language lent an aura of statistical certainty to these heavily selective accounts. At professional meetings, Freeman projected vivid slides and surgical films, presenting lobotomy as a humane way to liberate patients and relieve institutional overcrowding. Applause often drowned out dissenting voices. Some neurosurgeons criticized the crudeness of the technique and its disregard for brain anatomy, while psychiatrists expressed concern over flattened personalities and ethical boundaries. Yet, in an era anxious about social order, many framed the procedure as a necessary compromise, complexity sacrificed in exchange for manageability. By the late 1940s, the optimistic headlines surrounding lobotomy began to erode under the weight of hospital statistics. Surgical logs and follow-up notes quietly listed brain hemorrhages, postoperative seizures, and cases of incontinence that never resolved. Some patients died soon after the operation. Others survived with profound apathy and blunted personality. Ward staff recorded sudden changes. Once restless and tormented individuals now sat motionless, their symptoms muted but their initiative seemingly erased. In 1947, a review by the United States Veterans Administration surveyed outcomes among former soldiers who had undergone psychosurgery. Its findings, alongside early 1950s analyses by psychiatrists such as William Sargent, highlighted troubling patterns: marked weight gain, emotional flattening, and a striking loss of ambition. Relapses of psychosis remained common. Oral histories from nurses and relatives spoke of patients who stared at walls for hours, no longer besieged by delusions, yet no longer engaged with work, family, or hobbies. As more data accumulated, the image of lobotomy as a precise, life-restoring procedure fractured. Medical journals began to publish sober critiques, stressing the crude, non-specific nature of the cuts and the lack of reliable criteria for choosing candidates. Reports compared widely differing techniques and outcomes, underscoring the operation's unpredictability. In the 1950s, legal challenges and press investigations amplified public unease, confronting surgeons with the charge that they had traded madness for permanent neurological disability. By the early 1950s, a quiet revolution had begun in the laboratory rather than the operating theater. In 1952, French researchers synthesized chlorpromazine, later marketed as thorazine. Clinicians observed that, when given orally, it reduced hallucinations, calmed severe agitation, and eased paranoid delusions, without cutting into the skull. Early clinical trials in psychiatric hospitals showed wards growing calmer, suggesting that chemistry might succeed where crude surgical destruction of brain tissue had once been tried. Throughout the 1950s, new antipsychotics, antidepressants, and anxiolytics entered clinical practice. These drugs did not cure mental illness, but they offered a less invasive, adjustable approach. Doses could be raised, lowered, or discontinued. At the same time, psychoanalytic and psychotherapeutic ideas gained ground, emphasizing dialogue, childhood experience, and emotional conflict. Psychiatry slowly reoriented itself from a discipline of irreversible physical intervention toward one that increasingly valued psychological understanding and long-term relational care. Institutional attitudes shifted as the risks of psychosurgery became harder to ignore. Medical organizations, including the American Psychiatric Association, issued more cautious statements, urging strict indications and oversight. In 1967, a demonstration lobotomy ended in catastrophe when a surgical instrument penetrated too far into a patient's brain, causing a fatal hemorrhage. Public and professional outrage followed. Hospitals withdrew support. Training programs abandoned the technique, and by the late 1960s, transorbital lobotomy had largely disappeared from mainstream psychiatry. Only tightly regulated procedures such as cingulotomy persisted at the margins. By the late 1960s and 1970s, the ice pick lobotomy had become a disturbing symbol of psychiatric overreach. Journalists, former patients, and families publicly questioned how such a brutal, poorly studied procedure had been so widely accepted. U.S. congressional hearings on psychosurgery and mental health care examined past lobotomies and emerging brain surgery proposals. Lawmakers and experts debated patient rights, scientific evidence, and the role of state institutions in authorizing irreversible operations. Out of these investigations, tighter ethical frameworks emerged. Institutional review boards became central to overseeing research on human subjects, including psychiatric and neurosurgical experiments. Informed consent requirements grew more explicit, especially for patients under state care or with impaired decision-making. Scholars dissected the history of lobotomy, showing how overcrowded asylums, scarce treatments, and public fear of mental illness had made extreme interventions appear not only acceptable, but urgently necessary, despite limited proof of benefit. Modern practices such as deep brain stimulation and experimental brain implants stood in sharp contrast to the era of the ice-pick lobotomy. These newer techniques were subjected to rigorous trials, ethics committees, and ongoing monitoring, all shaped by the memory of earlier abuses. The story returned to the confident scenes of Walter Freeman in state hospitals, now overshadowed by the reality of thousands whose frontal lobes were pierced through the eye, a reminder that medical progress always carried a legacy of harm.